Parshios of Sarah Imenu, who at the end of Parshas Noach was told that she didn't have a uterus, Ein Lav Alad, and this parsha she gets her period back, and then she has a baby. I was thinking maybe a quick Dvar Torah as we wait. It's interesting that the pasuk with Rivka, because we know that Rivka also didn't have a uterus. The Medrash tells us that Rivka was also born without a uterus, but the pasuk says when she was pregnant with Yaakov and Esav, the pasuk says Vayisrotetzu habanim bikirba. You know, when you talk to your children and you tell your children that mommy has a baby in her belly, so you say the word belly. But I can't think of two other doctors that that can confirm this, that the baby is not in your belly, it's in your uterus. So why didn't the Torah use the word berachama? Vayisrotetzu habanim berachama. So perhaps one could suggest, and I didn't see this anywhere, this is my own thought, so feel free to disagree. But the difference between Rachel, the difference between Sarah and Rivka is that neither of them were born with a uterus, but Sarah miraculously was given her uterus back, and she was pierced in this parsha. She actually gets her period, and then she conceives and she gives birth from that uterus. But perhaps one could suggest that Rivka was never born with a uterus, as the Medrash tells us, and Vayisrotetzu habanim bikirba, she actually was pregnant with twins without a uterus. That she never had a uterus when she was born, and she was never given a uterus. And that's why it doesn't say Bekirba, that's why it says Berachma. And then we can have a better understanding of how Yaakov and Esav fought over the Bechorah, how Yaakov took the Bechorah from the Esav. The Bechorah is a din in Pet Rechem. The Bechorah is a din in Rechem. Rivka never had a Rechem. And therefore, when they were born in a pregnancy outside of the uterus, which is completely miraculous, but that's what perhaps took place. So maybe you could suggest that was the miracle that took place with Rivka, very different than the miracle that took place with Sarah. Anyway, so we have a number of people here joining us today. I know we have a number of people watching. Will watch the recording, and I welcome everyone to our third webinar of this AI Next Gen series, where we talk about innovative and unbelievable contributions that the world of AI has brought to the world of fertility. And it is a real honor this evening to have two very, very special guests with us tonight. We have Dr. Larry Platt. Anyone who lives in Los Angeles, and I'm sure people from even outside of LA know the name Dr. Platt. Dr. Platt is a staple in MFM, in maternal fetal care here in LA. He's been practicing this field of OBGYN, maternal fetal medicine, imaging for close to 50 years. Dr. Platt is a tremendous asset to the Jewish community, to the Jewish medical community. He is always on call, and it is an amazing schus that I have personally to be on this webinar with Dr. Platt, as I've called him so many times, needing an eitzah, needing to help a patient, whatever it is, and Dr. Platt is always there. He always picks up the phone, and he's always extremely helpful. So it's an amazing opportunity to have Dr. Platt with us. And I would like to introduce everyone to Dr. Nadav Schwartz. Dr. Schwartz is a professor and director of imaging in the Department of OBGYN and Maternal Fetal Medicine in the University of Pennsylvania. Also, we don't recognize and appreciate the value of Jewish doctors in the medical field, who are not only professionals and experts, but also assets to the Jewish community, always looking to help, always looking to be there for the community. It's a special schos that we have the two of you here tonight. And the topic of tonight's discussion is one as a new product that is coming to the field, which will really revolutionize the way that we monitor pregnancies. And I don't want to take too much of the time because I really want to throw it to the professionals. But I want to talk about this new innovative tool called the Nuvo belt, I think. I mean, maybe even there's a better name to use, and we'll hear from the experts. But when I was introduced to this concept, that there can be a device which can monitor pregnancy from afar, that you don't necessarily have to come into your doctor's office. And not only that, that there's a way to monitor and to uncover, discover, and to really see what's going on in the pregnancy more than we've ever done before, I said to some people on our team in Pua that we need to have a webinar about this. We need to bring this to the world. We need to publicize this. And it's a big schluss that Dr. Platt and Dr. Schwartz, who are both advisors on this product, are here tonight to talk about this innovative tool, this innovative technique. We'll learn a little bit about how it's being used, what the future brings, and how helpful it can be to multi-fetal maternal care. Dr. Platt, why don't you tell us a little bit about how you got involved in this? What is the product? Have you used it? How do you use it? And then we'll hear from Dr. Schwartz, and we'll really. I'm very, very excited for this fascinating discussion.
Thank you very much, Rabbi Segelman. I truly appreciate the opportunity to participate with you and Dr. Schwartz. I will be a bit more humble to say that the person who has spent a lot of time with this product is Dr. Schwartz. And as you know, initially I was going to be the only one on this presentation because I do work with it. But Dr. Schwartz, who is at University of Pennsylvania, as you mentioned, is really a mumcha in this because he really is someone who's spent his sabbatical in Israel working with this product, developing and doing research and publishing it, which is really where the breakthroughs come in. It's good to develop something, but if you don't prove its value, it doesn't mean anything. And I think that's one of the things that you'll hear from Dr. Schwartz, the kinds of things that are happening. I'd like to step back a bit, and I'm going to share my screen, and you'll see a little bit of what I'm going to do. And I'm going to take it in a little bit different direction. And that is, I'll title it, this doesn't need to be here, okay. Pregnancy and fetal monitoring, then, now, and in the future. Because this has really been going on for a long time. Can you see my screen, everyone? Okay, great. So that's good, it's not going now, so that's exactly what I thought would happen. Okay, hold on.
We saw the second slide.
Oh, you did, okay. More than I saw. Oh, so what I really wanted to show you is this remote monitoring. While we all talk about remote care, and for those of us now having gone through the pandemic, realize that transformed this remote care overnight. It changed our thought process of, can you do things at a distance? Not only then out of need, necessity, but sometimes out of convenience, and making it not just convenience for the healthcare provider, but for the patient. And you're going to hear a lot about that in this presentation. But if we think about it, back in 1983, what was our most famous remote monitoring was fetal kick counts. We asked the mother to tell us, is the baby moving okay? And Dr. Eliyahu Sadovsky in Israel in the 70s was telling his patients, count the number of times the babies kick in an hour, in 5 hours, in 3 hours, or subjective. So when you see those changes, it's really important to see that we do that. And what we showed is that the benefit of counting kicks at a remote way from your home, from your work, wherever you are, it really helped not just high-risk pregnancies, but low-risk pregnancies. It was able to help reduce the issues that we get at of stillbirth, which we know is important. But then comes the aspect of the role of the non-stress test. I was fortunate enough to spend the first 14 years of my career after my residency at University of Southern California, from the fellowship to the faculty. USC, those of you who know USC in LA know, at one time, it was the busiest obstetrical hospital in the United States, 18,000 deliveries a year in one facility. But in that facility was the man who created the fetal monitor and the man who helped develop ways to use it, including other faculty, Dr. Roger Freeman, Dr. Richard Paul, Dr. Ted Quillian, who developed the use of the fetal monitor in an outpatient setting, in an antepartum pacing. And knowing that these patients have to come into the hospital and have this testing, or come to your clinic, and for many women who may have children at home, it's an hour or two to get there and the same back, or who's taking care of their babies, who's babysitting for them. So the role of remote monitoring and non-stress tests, I believe, has been really revolutionized by this Nuvo, which Dr. Schwartz will now talk about at length. Without further ado, Nadav. I'll stop sharing my screen. It's all your turn.
Okay, you guys can hear me okay?
Yep.
So thank you, and thank you all for having me. And I feel like it's a great opportunity to, in general, put a Jewish stamp on the field, taking care of patients, but also trying to pave the way for the future. And I think that this is a great example of a device that I was fortunate enough to start working with back in 2017. And I'm going to go through a bunch of slides. I'm going to give you some of the science behind things, try to give you a sense of how it gets used clinically and some of the clinical use cases, some of the research we're currently doing, and some of the things that are coming down the pike. So we know that in general for prenatal care, it's very important. I probably don't have to talk to this group about what the different roles of prenatal care are to make sure we monitor for complications and help get to a nice, happy, healthy outcome. And traditionally, there's a lot of visits that are in person. The conventional structure is a 13 to 14 in-person visits, and that's without the ultrasounds on top of that. And that's difficult. And that was a model for decades, if not longer. And in the more complicated world, and there's a lot of multitasking and difficulty getting to these appointments. It really is disruptive. And the field in general has tried to move towards more efficiency, but we do know that we do need to get this care done. Inadequate prenatal care is associated with prematurity, with stillbirth, with neonatal death. So we do need to get this care done. And in addition, we try to tell people if they're low risk versus high risk, but up to a quarter or more patients who are considered quote unquote low risk will still have some sort of unexpected something happen during their pregnancy that requires some sort of deviation from routine care. So we can't put anybody in a box and expect them to have, unfortunately, I tell patients there's no such thing as a zero risk pregnancy. So any tools that we have to try to identify who's at most risk and then make it easy for them to get care is really critical. And there's been movement in the field to try to move away from these 13 to 14 in-person visits. And there's different models out there that American College of OBGYN and others have put out there, trying to move towards more virtual visits for prenatal care. And you'll see whether you don't have medical conditions or you do have medical conditions. You can see a lot of these visits can be moved virtually, which is amazing. And the main way they do that is mostly with remote blood pressure readings, maybe remote weight checks, but not a lot of attention to the fetus in this kind of model. In fact, one of the things that COVID pandemic did for us was it really tried to stimulate, the evolution and the transforming of care to remote because people were afraid of how to deliver care during the pandemic. And a lot of the models that were put out there about how we were guided to what to do, they would sneak in a lot of these virtual visits. And again, it was mostly related to blood pressure, telephone calls, maybe video chats, things like that. But they didn't have a lot of tools for the fetus itself. And so when they put out, we have all this guidance about all these patients that have risk factors and need extra monitoring, put the baby on the monitor, or do some sort of test. And yet we're telling them, sorry, we don't have anything better to offer you, even though there's the COVID pandemic. And so all of these strategies that came out in during the pandemic, they would say things like no modifications of fetal testing, is recommended if there's a risk factor for stillbirth, or it could be modified, but tell the patient she's taking some risk because we had no tools. And so you had the highest risk patients who needed the most help were the ones that were told, sorry, you still come in as frequently as we always told you to, because we don't have any better tools for you. And so just to put it into context, just hypothetical cases, but these things happen, unfortunately, on a daily or if not maybe weekly basis where we have these bad outcomes when you have a large center of high-risk patients. So you take a patient who is recommended to have twice weekly monitoring with non-stress tests after 32 weeks, a very common regimen for somebody who lost a pregnancy in the past, unfortunately. But, as much as we say she lost her pregnancy, she'll do anything to have a healthy pregnancy. There's the reality of life. She has two kids at home. Her husband's working long hours. She can't afford the child care. It's not so simple to just, put everything on hold and come in a couple times a week. And sure enough, we have a lot of patients who just have to make that decision in real life. Maybe there's a little bit denial that it can happen again, but unfortunately, these things do happen. And that is something that should be preventable. And there's a lot of different kinds of barriers to care. It could be related to work, childcare, transportation, mental health, and the motivation to do it, or the denial and other things that are going on in your life. And then thinking broadly across the country and let alone across the world, there's, not everybody has a doctor down the block. Not everybody lives in a, tight urban environment where they can just, go 5 minutes and be at their doctor's office. There's 50% of the counties in the country don't even have any OB providing provider whatsoever. And so there are times, and again, unfortunately, I've seen this situation, regardless of what the person's background is, regardless of their financial situation, where they just have to make a human decision. So here is somebody who baby's not moving so well. Dr. Platt mentioned fetal kick counts. Fetal kick counts were so important and relatively easy, but there is a false positive. Sometimes people get, comment, most of the time, thankfully, everything's fine. Well, this person, she already had an episode of decreased fetal kick counts, went in, got, monitored for a while and was sent home. So false alarm. Sure enough, the next time at 10 o'clock at night, I'm tired, it's a long day. I'll just, if the baby's not moving in the morning, then I'll go into the office. And unfortunately, and there's data behind this, that's a common presentation of a stillbirth when somebody isn't sure about the baby's movement in the evening, and then all of a sudden in the morning, it's too late. So the convenience factor, the human factor of being able to make it as easy as possible to check on these pregnancies is really critical. Now, again, I know it's a mixed audience, and I'm not going to get into too much medical detail, but there's a lot of different kinds of tests that we do for the baby, and most of them need like some sort of medical device. And the old-fashioned test down here, the contraction stress test on the bottom, that was how the testing was done for many years, but like 50 years ago and 40, 50 years ago and more. It's not so commonly used nowadays, once in a while. But the other things that we do, the non-stress test, which is still needs a CTG device, which is the baby monitor, or the biophysical profiles, which need the baby monitor and an ultrasound. Those are the most common tests. And you see they all have a very good negative predictive value, means if that test looks good, the chance of a stillbirth in the coming days is thankfully very low. But the question is, currently in standard of care, they're not amenable to telehealth. The non-stress test needs a medical person to put the monitor on, find the baby, make sure the baby's not moving, interpret it. And the biophysical needs the ultrasound, which again, currently in terms of standard of care is also done by a medical professional. But that's what's changing now. And what we're going to talk a lot about is this ability now to do remote non-stress testing at home. And then Dr. Platt at the end will talk about the fact that even remote ultrasound is coming down the pike and coming soon, to really revolutionize how we treat patients and bring the care to the patient as much as possible. And as it was mentioned earlier, just recently, this is the device that I've been working with since 2017. Just now in 2024 was listed in Time Magazine as one of the best inventions of 2024. And it's one of 9 Israeli products, so nice Israeli pride here, of all the innovation that gets done in Eretz Israel. And we have 9 products on the Times Best Invention, and the one in healthcare is this InView device. It's the InView pregnancy monitor. The name of the company is Nuvo, but the name of the belt is InView. And we'll talk a little bit about that. And the idea is to try to transition from this picture over here, where we see somebody being strapped down with all these wired devices in a medical setting, to be able to comfortably do this from home, remotely talk to your provider, be able to use the technology to be able to get monitored. And using the cloud nowadays, be able to process this information to be able to get you the standard of care surveillance, which is looking at the maternal heart rate, the fetal heart rate, and the contraction pattern. And what's even more exciting, especially for an academic clinician like me, is doing the research to really push the needle to the next generation set of tools. And so it's one of the things that is special about this device is that, first of all, it's a fixed array, which means that there are sensors all over the belly here, on top and on bottom. So you don't have to start chasing the baby. You set it and forget it. The multimodal sensors, which means that it has on the other side of the belt here, there's lots of different kinds of sensors. There's the biopotential, which means like an EKG or electricity. There's the acoustic sensor, which is actually listening to the changes in sound. There's movement sensors and gyroscopes, and all those things get put together and processed to get you on the algorithms to get you the output that we need. And most importantly, it's actually FDA cleared. And I was one of the sites here at Penn that helped get the data to send to the FDA to get it cleared a year and a half ago or so. So one of the earliest studies in the way when I first got involved was a 4-site study, including in Hadassah in Israel. And we just wanted to compare and show that this device is accurate in terms of picking up maternal and fetal heart rate. And we showed that that was successful. The more challenging thing, and this is where AI started to come in, was how do you measure the contractions? First of all, this is an outpatient study. Not a lot of people are having contractions as an outpatient. It's not in labor. And how are we going to detect it reliably? So that's where the scientists at Nuvo really came up with something really creative, which I like to share because I'm impressed with it, even if it's a little bit nerdy. But basically, they say what's the strongest signal in the body is actually going to be the maternal heartbeat, not the baby's heartbeat, which is tiny. And as the maternal heart rate is going through the belly, it's being picked up by these sensors as well. And it creates an ECG and a PCG. PCG is a sound waves. So there's sound modulation and electric modulation of the maternal heart rate through the belly. And then when the uterus contracts, the actual tissue that the waves are going through, that the signals are going through for the maternal heart is changing. And that actually changes these signals. It modulates the ECG, PCG signals. And that is actually being able to detect the contraction. So what we're detecting is how does the shape of the uterus and the density of the uterus modify the maternal heart signals? And that, it sounds like convoluted and indirect, but it's actually pretty accurate and is picking up the actual real conformational change of the uterus as a contraction. And we then validated that in another trial where we actually took patients in labor and recruited them to wear the device for up to 30 to 60 minutes, while they also had an intrauterine pressure catheter, which is a more invasive technique to measure the contractions, the gold standard for contractions. And we showed that, here we see what the InView device did compared to the intrauterine catheter. And we also, in some cases, had the regular external monitor. And sometimes everything looked great. They all look pretty similar. But then there were times that the regular clinical monitor on the bottom here, since it's so sensitive to positioning and so sensitive to the body's shape and size, it didn't pick up, and yet the InView device still picked up. And it was much more accurate than the external device. And it also was accurate regardless of the patient's body mass index. So even patients that were on the heavier side where the external device isn't as good, this device was still able to pick it up. So it just showed that not only is it replicating standard of care, it's actually exceeding standard of care in terms of contraction monitoring. So we got some research grants here at Penn, some from the NIH and some internally, and we did some trials. And this is one pilot that we published on 131 non-stress tests that were done at home. So we trained the patient how to do it in the office, and then we sent them home. And we showed that 94% of the time they were able to get their non-stress tests at home. So they were able to follow the instructions that we had given them and able to get a non-stress test. We looked at it remotely, and 90% of the time they were able to avoid having to come in at all. And this is like our early experience with the device. And the only people that ever had to be delivered because of a non-stress test, it wasn't because the monitor was a problem. It's just because they had a high blood pressure or some other symptom. And so they came in because if they broke the water, they're going to come in, nothing to do with the device. So overall, it was successful pilot. It showed that it was feasible. The patients had great feedback. 96% said they would want to use this in a future pregnancy. And then this is data from outside of the research world, because the question is always like, if somebody's doing a research trial, maybe they're getting more attention, or maybe they're a different kind of patient that signs up for research. But what's happening in the real world? And so just recently, we looked at the data that Nuvo has in their repository, and over 2,000 non-stress tests that were done not as part of an IRB trial in an academic site, but from customers like health centers that are using the device commercially. And over 2,000 non-stress tests between America and Israel. And again, a 93% success rate that the patient was able to successfully get the non-stress test done at home. And we show that, and this is data that's going to be presented at our national meeting in January. But it showed that the success rate of the non-stress test was stable over a wide range of body mass index. It wasn't until a body mass index of 50 where there's starting to be a little bit of a less effectiveness. So the vast majority of patients, similarly, for 32 weeks and above, very strong throughout, as well as appointment number, like how much experience they had at their second and third visit versus their first visit, and overall excellent success rates. So briefly, how does that work in practice? If somebody were to have this device, we don't want it to be a situation where a patient puts themselves on the monitor without the guidance of a provider. They don't know how to interpret it. In fact, we don't even show the patient all the data. We want it to be a prescription-based concept where it's being done by the medical professional. So the clinician would be prescribing the InView. It gets shipped to the patient, or the clinician could give it to the patient. They get a kit. The app that they download is free, and they register, and they're able to then complete all of the instructions about how to do a session, how to put it on. They go through training sessions, And then they get a care plan from the provider, how often the provider wants them to do it and when. They get the remote monitoring done. The clinician's able to see all the information. They're able to chat, communicate, they review the data, get instructions, and then the provider can document it into their medical record. The patient can ask questions, the clinician can ask questions, they can communicate through the app, they can chat through the app, and the patients actually feel very engaged and cared for, but from the comfort of their own home. Now, overall, now different sites that have been using Nuvo over the last 2 years or so. This is Israel, of course, and then different sites in Hawaii, where you wouldn't even think about the things people have to do to get to a doctor in Hawaii when there's an island hopping every time they want to see a provider, and of course throughout the Midwest and a lot of activity in Texas as well. And there's a lot of secondary benefits that we're finding that make sense. High patient preference to be able to have that flexibility. For patients that have anxiety, they're able to feel that they can get a monitoring device, monitoring session. If a patient has a complaint and they call their doctor, instead of being sent into the hospital, if they have a device at home, the provider can open up a new session, say, oh, you're not feeling the baby move? Let me open a session for you. And you could do it right then and there remotely from home. And that engagement is really important in both mental health, but also just getting engaged patients actually have better outcomes. And then less emergency room visits, which is not just costly to the system, but obviously a very stressful situation. And once you touch the hospital in the emergency room, you never know what's going to happen in terms of an intervention. This is from a practice in Texas showing, and they have used this device for a bunch, and they showed their practice is more efficient. They're 50% decrease in the nursing time. The patient between the commuting and the time in the hospital have saved over an hour per session on average, because in Texas, you have to drive to your doctor a lot. A lot of people did it at work. You had school teachers who didn't want to take a whole day off every time they had a visit. They just did it during their lunch break. And they had better compliance rates, and they were able to avoid emergency room visits. And the satisfaction scores were through the roof. This is an ongoing trial we do now. I have an NIH grant to actually get data from the states to be able to help push policy changes on the national level, also to push policy changes with payers. And it's a randomized trial that we're almost 3/4 of the way done. We're trying to get 400 patients enrolled. They're high-risk patients that have clinical reasons to have non-stress tests, and they're being randomized to either do it in the office or do it at home. And as of a couple of weeks ago, we had 246 enrolled, and we're hoping to be done by this summer. And that'll hopefully give us very valuable data to help push the envelope and get confidence, by all the stakeholders, and especially with the policymakers and the payers. Another important potential utility is dehospitalization. So we know that some patients have to be in the hospital for a while. It's very, very stressful. Separation from family, mental health, loss of income. There's a lot of stuff, hesitancy to be in the hospital for good reason related to like what infections or what viruses are hanging out in the hospital, what exposures you're getting, and obviously the cost to the health system. And I'm not saying that every single person cannot be in the hospital. Obviously, some people need to be in the hospital, but there's no question that a lot of the reason why some diagnoses, some situations, patients are in the hospital longer than they could otherwise be is because of that concern of how do we monitor the fetus at home. And I've spoken to practices around the country, again, especially in places where people have to travel a lot, where patients, even every time there's a small baby at the third trimester, instead of just coming in 2-3 times a week to get checked out, they're just admitting the patients for 2-3 weeks on end because of that nervous concern that they aren't able to put the baby on the monitor at home. And so that's another potential utility. It's not a standard of care by any means, but it's something that I'm excited to sort of push forward in the coming years. In fact, there's data from Europe, Denmark and the Netherlands. They've done remote monitoring for a while now, and they have a big national initiative to do this in their health systems. And this is a retrospective study of over 400 patients where they dehospitalize patients, including people that have broken their water preterm, and sent them home with frequent monitoring remotely to see how that worked, and they had excellent outcomes. The hotel trial, which was just published last year in the Lancet Digital Health, they randomized also patients to home every day on the monitor or coming into the office or the hospital. And they showed lower adverse outcomes being at home. They showed lower preterm birth being at home. And most importantly, patient satisfaction, patient mental health, and healthcare costs were far improved by allowing the patients to be at home. So it is a new frontier that's being pushed forward, and we're excited to be a part of it. Also excited, I think Dr. Platt mentioned that I was blessed to be able to spend a year with my family in Israel doing research and working with the company, to try to understand it better, to help push forward their commercialization plan as well as an innovation plan. But I also got exposed to some of the health system in Israel. And Avi Tzur, who's the director of women's health at Sheba, which is the largest largest hospital in Israel, and it's also one of the top 10 hospitals in the world, according to some lists. And he's pushing the concept of dehospitalization using not just the InView developed, but also remote ultrasound, as Dr. Platt will talk about in a few minutes, and other tools trying to leverage technology. In fact, during this unfortunate war in Israel, he's dehospitalized almost 100 patients that would have been in the hospital to clear up space in the hospital for wounded, and been able to monitor them successfully at home. And so, once again, we're leading the way in terms of trying to leverage technology creatively, safely, with high quality, to be able to meet the patients where they're at, and move the needle. Now, just a couple of slides on what I think some other future innovations, where I think that this technology, it's not just about being remote. That's the first level. That's super important. I think that's where we need to start. But once we now digitize this data, and we have it in a format that we can get a lot more meaningful insights into the pregnancy health, into the fetal health, that I think will change what our understanding of pregnancy, like Dr. Segelman was saying, like what can we better understand what's going on inside. Right now, we know that we can try to estimate how big the baby is. We can try to measure the fluid around the baby. We can look at some movements, but it's very difficult to really discern which baby might be in trouble, which one isn't in trouble. And as much monitoring as we do, as I mentioned earlier, even low-risk pregnancies who currently are not getting monitored, unfortunately, can have bad outcomes, and then they turn into a high-risk pregnancy for the next time. But that's obviously most unfortunate. And so if we can find better insights into the pregnancy with this new data, then we will be able to, I think, break through to the next frontier. So just as one example, this device is not only able to measure the baby's heart rate, but with these signals can actually recreate a fetal EKG, which is currently not a clinically available tool, right? So if somebody's not feeling well and they go to their cardiologist, you get an EKG to see how the heart's doing. Well, all we're doing for the fetus is measuring the heart rate. That's only a very small vital sign compared to what we would really want from the fetus. So being able to non-invasively get a fetal EKG would really open the door to a lot more potential insights into how the baby's doing. Are there any signs of stress in the baby's heart or their baby's response to its environment? And there are a lot of potential clinical applications for normal fetuses, for fetuses with certain heart disease, and then a lot of better understanding as to how the heart function is going to sort of be a marker for the overall well-being of the fetus. Another very unique part of the InView device I mentioned earlier, that it's a multimodal sensor, meaning that there's more than one kind of sensor. It's not just ECG. One of them is called a PCG, or the phonocardiography. Phonocardiography means sound. And so this device can actually hear the different heart sounds of the fetus, S1 and S2. And here we're just showing it in comparison to the ultrasound on fetal echo, where we can see the valves opening and closing. This is something that, again, a cardiologist listening to an adult or a child would use this in assessing the cardiac function. We can't do that on a fetus, definitely not at home. But with this device, there's that potential to start collecting that data on fetuses non-invasively and serially at home, to find new biomarkers to understand how to differentiate it and identify the fetuses at most at risk. And that's just the near term. I think there's a lot of other things that we can do. We can start figuring out fetal position, and so we don't have these surprise fetuses that show up in labor, but they're breech, and now they may need a C-section that could have been avoided if we would have known earlier. There's a lot of science being done in beat-to-beat heart rate variability and as a marker of the autonomic nervous system. The sensors can also pick up fetal movement, and even though, as Dr. Platt mentioned, back in the day, people developing fetal kick counts, people developing the biophysical profile to look at how many movements we should expect, it was done very relatively crudely. People sitting there just watching with an ultrasound because that's a tool they had. And of course, the giants like Dr. Platt found ways to leverage that into a clinical tool. But imagine now being able to do that on that next level of granularity, where we can actually map out fetal movement patterns and really understand what the normal and abnormal states are. And there's a lot more to come from that as well: preterm labor, term labor prediction, etc. And so I'm
Dr.
just
Schwartz,
excited to be part of this.
someone
I'm
asked a
excited.
question about. Oh, sorry, if someone asked a question about C-sections, how many C-sections do you think, um, in at least in the United States, are performed when a vaginal delivery could have been exercised then safely, and how can this device help prevent unnecessary C-sections?
I think that is a very good question. It's definitely varies regionally. I do think that there are a lot of C-sections that are potentially preventable. The problem is that the tools are the reason why the C-sections are happening. Let's have the benefit of the doubt. It's not just because the doctor wants to go play golf and therefore let's do a C-section. Unfortunately, that probably does happen in some places, but let's take that out of it for a second. We
Right.
just don't have great tools to understand what a true positive, fetus is in trouble, fetus needs to come out, and what a false positive is. And we need better understanding as to a better vital signs. We are now limited by technology that we can't really assess the fetus the way we would want to. And the hope is that devices like this, and again, right now, InView is an outpatient device before labor. This is not a device in labor. This is trying to identify the patients prior to labor. But we need those tools. One thing I think that the InView device can help with, for example, is right now I feel like there are a lot of people that are once you go to the hospital for any reason in pregnancy, it makes sense that your statistical chance of getting an intervention, of getting induced or getting um, pushed down the road of delivery is going to be higher. And a lot of times, again, it's because people are nervous and they don't have real insight in terms of what's going on in the fetus, and they don't want to take a chance. And those interventions lead to potentially increased risk in C-section, increased risk in C-section. But by having devices that can better keep the patient at home, keep the patient on the monitor a little bit longer to make sure the baby really is doing okay, and before they actually get into the hospital, I think that that's a potential mechanism by which we can lower the C-section rate. I think the better we understand the baby, the better we'll be sort of armed with information.
I think I might add, if I can, in terms of risk and lowering cesarean section, it's not just about the risk itself. I think as we learn more about who will get in trouble, who will not get in trouble, using this technology, using AI, it'll help us reduce the section. Let's not fool ourselves. A lot of sections are done to prevent concern about medical legal risk. If I keep going vaginally and the baby gets obstructed and I cause a problem, I'm worried about getting sued. That's an environment that's real. We can't ignore it. And until we have all the tools like this that will help us do better prediction, I'm afraid we're not going to lower it that much, because today, I think those of us that practice in hospitals or help involved in the running of departments know that very clearly cesarean section rate is a marker for reimbursement, and hospitals are penalized if their cesarean section rates are too high, and timeliness becomes important. So as we get tools like this that provide more information for us, I think we'll have that chance of lowering section rate, but we'll need that information.
Great.
I agree, and I think that there's like a two-pronged issue here. There's the before the admission to the hospital, and then there's the labor process itself. And a lot of focus is, and I have colleagues working on this as well, doing AI on the fetal monitoring strip during labor to try to really get a sense as to which fetuses are really in trouble and which aren't. And there's work being done. It's not there yet. The science isn't there yet to help. Although again, better data would be very valuable.
You
But
know,
I also think that what we don't have is the ability to understand, you know, what is the main source of oxygen and energy to the pregnancy? It's the placenta. The placenta is what's getting the oxygen and nutrition from the mom to the fetus. And generally, even in a patient who's in labor and the fetus isn't happy, mom's oxygen levels are fine. Mom has plenty of nutrition in her. Mom has plenty of fluid in her. But why is it not getting to the fetus during labor? And that's the placenta. And so we don't have great ways of understanding which placentas are sort of on their last legs and which ones aren't. I tell patients sometimes that, the placenta is not meant to be recycled. You get one and you're done for the next pregnancy, you got a new one, because they all start failing at some point. That's why there's higher C-section rates and higher adverse outcomes when, 2 weeks after your due date, because those placentas are really, really not doing well. So again, if we can time delivery better, because we understand which placentas are really in trouble and which ones won't have the reserve to tolerate a labor and which ones will, again, another potential mechanism for that. But this was actually my last slide, and I was going to, as a segue back to Dr. Platt, in terms of, again, there are many companies and many countries that are doing this, but I'm just proud of what the Israeli health tech industry is doing. But this is just an example, even before the current war and before, and this is not even for the InView device per se, but Sheba leads the world in using virtual care to go to trouble spots around the world and actually help. And this is an example on the Ukrainian border where they sent these pulse and devices to the refugees that were escaping from the Ukraine into the neighboring countries, and giving them virtual care from thousands of kilometers away. And this kind of technology can really go a long way to not just helping people in our neighborhood, people in our communities, but just thinking more globally for the greater good. These technologies are really set to try to really do a lot of good in the world, and proud that that this is one of the many Israeli innovations that are leading the way in that field. So that was my last slide.
All right.
Unbelievable. Really very, very impressive. Dr. Platt, Dr. Schwartz, is this device something that will be rolled out in the coming years? And it will be, as you said, standard care that every patient, when they get pregnant and they make an appointment with their OBGYN, they'll be given this belt. And this is the way maternal fetal medicine will look.
I think if you see what Dr. Schwartz just showed you, Rabbi, that those that use it and get used to using it realize the value that it brings, not just to the physician, but to the patient. And if we look today, the difficulty that clinicians have who run private practices, reimbursement rates are going down, costs are going up. Take a room that you need to do a non-stress test and a nurse to come in and administer it, and the physician to go in and check it. Now this all can be done at home. And the value is right then and there. He showed beautifully the data of how many hours they save in the couple of studies you showed. And our experience, as I probably will highlight maybe, we've been doing in women who have stillbirths. And let me tell you, talk about a group of women who are anxious about their pregnancies. We're willing to do more than that 1 or 2 or 3 times a week. The minute they're anxious, put it on. I can't begin to tell you, and I'm sure Nadav will tell you the same, how many calls you get in the middle of the night. I don't feel the baby move, or in the afternoon. What do? You either send them to your office, you send them to the hospital. Put the monitor on and you see them. The question is cost. Right. Let's be honest. Who's going to pay for it? And I think I hope the studies will show the cost benefit value of this technology, overall care, and overall cost for institutions, individuals, insurance companies, and private payers, because it is a product that has great potential. And I think the presentation that Nadav talked about what else we can get from this device, or what we should be thinking about getting this device, is the next generation for sure. It's not just a simple non-stress test. It goes way beyond understanding the physiology of the fetus and how do we interpret it and how do we prevent complications. That's really what we're trying to do with it, isn't it? We want to know pregnancy can continue and whose can't. We talk about ultrasound, and I'll talk about that briefly. What is ultrasound? In many ways, it's long-term constant. How is the baby growing? What does the anatomy look like? What is this device? This is short-term. How is the baby now? How's it going to be in 2 days?
To use the parsha, Ba'asher Hu Sham.
Yeah, for sure. In your Dvar Torah, you talk about in the belly. Okay, that's probably the first case of an abdominal pregnancy, but that's okay. We can talk about that because we do see those occasionally. So it's nothing new. Ein chadash tachas hashemesh. We know that.
Right.
So we'll develop it again. So perhaps if I'll go over mine rather quickly, so we can leave 5-10 more minutes for questions, because I just want to show the device, and I'll really go quicker than I thought I'd do, because Nadav pointed out, if we couple this fetal monitor with ultrasound and the next device that will come along, we're really moving this, not just remote, not just telehealth, but instant health, and really feedback ways that we can analyze if we're doing a good thing. So I'm going to share my screen and get us back to where we were, and then go to. So if you look, as you heard Dr. Schwartz say, I've been very involved from my early research work in fetal breathing movements, the relationship that the percentage that the fetus spends breathing. And people say, the fetus breathes? Well, this is just a clip of a baby showing you, this is the color Doppler going in and coming in and out of the nose. Yes, the baby does make breathing movements, breathing-like movements. But yes, you're right. It doesn't breathe like you and I do. It's not an exchange of air. It doesn't have the lungs to do that. But it's like a prenatal practice. Think about it. If any of you have ever broken your arm and been in a cast or a leg, and they take the cast off, you can't move it so easily right away. Well, that's why the baby has to make these movements to get ready for birth. And so here's an example of what chest wall movements are. You can see it moving in and out. This happens in utero all of the time. It's real. It does make those movements that are there and make us see. So yes, that was in the 1960s. As I said, 70s, I was fortunate to work with Dr. Frank Manning at USC, where we developed the fetal biophysical profile. We kind of started to look at how we could use ultrasound to help assess the fetus, just like Dr. Schwartz talked about this monitor. What can we go to the next level? So if you think about it, what do we know about fetal tone? Well, everyone's had an APGAR score given to us at birth. Oh, check it out. Is it 10 out of 10? Is it 8 out of 10? Is it 6 out of 10? What was it? So what we said is, if you see a baby move, the arms open up, it must have some tone. And so the components of the biophysical profile, which Dr. Schwartz mentioned, is fetal breathing, fetal movements, as we talked about, the non-stress test, tone, and amniotic fluid volume. Well, it's great if this machine ultimately will be able to do all of it in itself, and yet it's not doing that. And what else can we do? So if you all know, we need the ultrasound machine to help us with the biophysical profile, which Nadav pointed out. Well, you're not going to take a machine this size at home. You're not going to put it in your car and move it there. It just is not going to happen. Yeah, there are occasional guy who has a truck and thinks they can bring it to your house and do it, but he's not giving it away, I promise you. He or she is charging dearly for it. That's not what we need. We need something that's very practical. And so we started to look at ultrasound. We said, oh, amniotic fluid, that's important because, it's a reflection of condition of the baby. As you can see, back in 1979, we reported this. And you heard Rabbi Segelman said, yeah, I've been around a long time. We've been doing this a long time. And by and large, this black area is amniotic fluid. It's really what we're seeing. And what you're seeing is the amount of fluid that's there is relative to condition of the baby. Less fluid means more problems for the baby. Baby's not getting that nutrition. The management of the baby, it's not peeing enough, because that's where amniotic fluid comes from. And so we first reported that if there's decreased fluid, less than a centimeter, the baby has a greater chance of being in trouble. A simple little test with a simple portable ultrasound back in the 1970s. We were too strict, we know it, but we tried something. And that goes back to the false positives and false negatives. We got to be careful with it. And so they developed the amniotic fluid volume index at USC when I was there with them as well. And it really looks at 4 quadrants of the abdomen. We won't go into the greater detail. But what we developed is a profile. We gave a score of 2 for each one. And guess what? It's an in utero APGAR score. But wouldn't it be nice to do that at home? Well, you got the non-stress test, but you don't have the ultrasound component. How are we going to do that? And this is what we showed you, that in the biophysical profile, that the higher the score, the less you're going to deal with fetal distress in labor, the less you're going to deal with perinatal mortality, which is what we're trying to do. We're trying to prevent stillbirth. So it does work. And, yes, I'm gratified that this test is still being used today. You heard Nadav pointed out, and sometimes we're probably better to be lucky than to be good. We've been very lucky with it, and it's still used. So what does the future hold for us? And there is where ultrasound monitoring plays a device. As I showed you, and I'm going to point out one of these in a moment, I'll show you it. Ultrasound has been miniaturized. From the first company that did it, sort of Sonosite, to other companies, everyone's got. I could bring you 4 or 5 different handheld machines right now. And I'm going to point out, if you see here, this is the Pulse and More machine. This is, again, created in Israel. very creative engineers. What you do is you put your phone in the device and you just put this on, I'll show you a video of it. And you can see how easy it is, how light it is. And I can hold it in the hand. And actually, it's for the patient. The patient gets to see the image and helps us prepare these exams. And here, if you use that in combination with the Nuvo device, and there are studies going on with the Nuvo device, which the company is participating in, you can imagine the reimagining prenatal care. And I'm going to go through this rather quickly. I'll skip this for time to show you that we know that there's a crossroad between our diagnostic capabilities. Trust me, this machine is not going to be like the $300,000 machine that I showed you that just passed by, but it does its job for what you're trying to do. We have to standardize the care for what is needed in a patient. And I'll show you so we can go quickly through it to show you device that this is where the patient has the device herself. She puts it on her abdomen. And as you can see, if you can see this screen, I'll have a bigger one in a minute. Oh, that one didn't work. Let's see. Okay, let's see. Okay. You can see that and she sees the image there herself. So I want to point out that that is clinician guidance, because guess what? That is transmitted through Wi-Fi to the clinician who has to originate the call to use that machine. So it's not to be used as a toy. I want an ultrasound device at home. And the neat thing about it, the cost of this, believe you me, is much less than what you think. It's probably going to cost less than $500 compared to the $300,000 machines that we use in our office right today. But then it's practical. So the patient who's not feeling the baby move, who wants to use the Nuvo, will do it for a non-stress test, will now have the device ability to do the biophysical profile, which Dr. Schwartz pointed out is in the future. Well, that future is closer than you think. The innovation that's coming out of Israel is spectacular. Yes, people have created ultrasound machines, but they haven't created the 2 and 4 one that allows us to see the things as we want to be able to do it.
Dr. Platt, the quality of the image with the handheld devices are really comparative to the 300,000, the ones that your doctor has in the office.
Okay, so great question. Is it going to be exactly like the other? You got to be kidding. No chance. Adequate? Right. Yes, because I want to know how much fluid is there. I want to know if the heart beating, okay, for example, but I want to know, is the baby moving? And remember what Nadav showed, we're trying to get the Nuvo to be able to help us with that as well, without this in a sense. But here the patient is reassured, she sees it, she gets it. We do the amniotic fluid index. She's taught how she can move this up and down her belly. I could show another one, but I'm not going to for time. It clearly is more than adequate. We've been part of the research to hopefully get this approved by the FDA. It's approved in Israel, it's approved in Europe, a lot of places, but it's not yet through the FDA, so it's not a commercial product yet available. It will be, I'm confident. Our site was one of the sites that was studying it in New York, Mount Sinai, and in Florida for the US, and hopefully in short time it will be. Again, cost benefit has to play a role in all that we do. Someone has to pay for this, the technology that we're doing. And this was an innovation, incredibly cost effectiveness if we think about it. But it's adequate to get the job done. And that's exactly what your question is, a perfect one, because that's what the FDA is asking. Is it good enough to get to answer the question you're asking? And that's what you need to know. This is not going to tell me that that the baby has a small muscular septal defect, or the valve is a little irregular, or it's a bicuspid valve, but it's going to help me with other things. So we have to know limitations, the limitations of what each of these products can do and cannot do. And it doesn't mean it won't be able to do it in the future. It may very well, because when I started doing ultrasound years ago, Okay, they used to say you can't use that real-time ultrasound to do an ultrasound exam. We used to have to send it to the radiologist to get a static ultrasound, move it up and down, and the next day they did the interpretation. I'll never forget. The residents kept challenging me because I said I can do this and let's do it. They said, "Aren't you going to get a formal ultrasound?" So let me tell you what I did. That very next day, I came to the hospital with tuxedo and I did a formal ultrasound. Okay, so
Yeah.
I mean, that's what you got to do to prove it. It takes time to prove it, and we will. They will. Innovation is here. It's here to stay. And again, if we rest on our laurels, we'll never get anything done. And so we look at what it does. This machine does no color right now. They're working on color development. Everything is incremental. They will get all these things done, but right now, will it combine with the Nuvo? I believe it will. They're doing a study in the University of Michigan of that right now, the fetal biophysical profile and the Nuvo. So I think it'll make a very big difference for what we do. These are stuff, again, I want to just, so for time's sake, when we have time for questions, remote telemedicine and fetal well-being is here. Nuvo is one of those products, as Time Magazine has recognized it. I think the Pulse and More products will merge together very lovely. I think that the roadmap is clear. We have to have the validation studies approved by the FDA. I hope in the near future, it will be very near future. Hold on a second. And I'm pretty sure it will happen. So when we do it, the bottom line is we want better maternal engagement. Nadav has showed that Nuvo has much better maternal engagement. It allows them to be in control. It improves remote monitoring and clinical decision-making. It definitely improves resource management, as I alluded to what it takes to do in my office, how many room it takes, staffing, equipment. I think it'll play an important role. And where we go in the future, let me just conclude. You started last week's seminar on artificial intelligence, clearly analyzing what we're doing, machine learning, all of this will play an integral part of what we're doing. I don't know how many of you use Chat GPT, try it, it's kind of fun. But I think at the end of the day, we have to open ourselves to the future. We have to be willing to listen, but we have to study. We can't just go out and do it. And I think the studies that Nadav has showed you being done are important, essential for us to move forward, which I'm absolutely convinced we will move forward. We will lower the perinatal mortality. We will lower the stillbirth rate. We will improve our outcomes because we're listening to innovation. And as Nadav said, thank God we can be very proud of our Israeli colleagues who are doing so much of this innovation work. And we hope, as Hashem, that this war will come to an end and that people will be able to get back to the time, because we've lost so much time during the time when all these people are middle women and taking care of things. I think we can open to questions at this point.
Unbelievable. I get when I heard about this product, I mean, Pua gets so many shilas daily about whether are we allowed to, questions like, are we allowed to induce, a patient's 40 weeks, the doctor says, we want you to induce. No, we don't want to be induced. What does halacha say about that? Do we have to get induced or not? And really, that's a very important question. What's going on? We'll get a question about VBAC. The doctor, we want to have a vaginal delivery. The doctor's insisting we have a C-section. Are we allowed al pi halacha to go ahead with the VBAC? Are questions about, generally speaking, the doctors and Dr. Platt, we've spoken about many patients where one couple is told, the doctor tells them, you're not allowed to get pregnant. It's a sakana to get pregnant. And they say, how could but we want to get pregnant. Well, I mean, it's a question of what is the safety of the mother? What's the safety of the baby? We actually need to know real answers, real-time answers. And of course, we get questions about abortion, and we get questions about, and a lot of the abortion questions, we don't actually know what's going on. And there's, the doctors have had their ultrasounds and whatnot, but very often it's a question mark. And I think that this product, after seeing Dr. Schwartz's presentation, Dr. Platt's presentation, I think for the listeners, it's so clear how valuable this technology will be for medicine in general, but also from the halachic component. There's so much that a Rav can be able to utilize in order to make the right most appropriate psak. I wanted to do, I still want to do Dr. Platt, I know that we discussed this, a research project about how fasting impacts the fetus. Because when it comes to Tisha B'Av and Yom Kippur, our phones are off the hook. Are we allowed to fast? Are we not allowed to fast? My Rav says I should fast. The doctor says we shouldn't fast. And sometimes it's a he said, she said. He said you should fast. She said not. Well, let's get the facts. Let's have a test where we're able to use this belt and to see exactly what the stress levels are of the baby once there's less fluid, more fluid, and this and that, and then it'll give us a really, really, really great insight into fasting on Yom Kippur, fasting on Tisha B'Av. I think there's so much that we can accomplish. There's so much amazing resource. This is such an amazing resource, and there's so much that can be helpful for the patient vis-a-vis their patient care, and for the Rav, and for the doctor, and for the clinician and the Rav. I think that as this technology rolls out and becomes more accessible, I think that hopefully we'll really see a turn, as you said, in medicine. We'll see a turn in halacha. We'll be able to really paskin shilos more accurately. And last question, Dr. Schwartz. I mean, Dr. Platt, are you using how regularly are you using this device with your patients? Are do you have any patients that are using it now? You have one patient? You have two patients? Do you have 100? What does it look like? Tell our listeners.
So again, the question that you have is cost benefit to using a large center right now. I'm using it in stillbirth patients. Anybody who is had a stillbirth is in my program to have this. That, like Nadav showed, some of the numbers that Nuvo has showed certainly comes from our unit, because we're doing it in stillbirths. I think we can use it more often. There's no question about it. I think it's one of the things that all of this takes is comfort level. I have comfort level with it. Does everyone out there have comfort level with it? You got to be, the important question you ask is this going to be good enough for a regular ultrasound? The answer is not. Right. I think that we learn over time, and that is where the data, it's got to be data driven. Nadav's done a beautiful job of that. The papers he quoted, the papers he's been involved with, the studies that the companies know they have to do. Even, I said we did all these cases for the FDA. They challenge them. It's not an automatic. If they look at each and every one, you have to be safety first, and this is the issue. So I'm going to throw it back in a different way to you, put a proposal out, and maybe Pua wants to lead it. We take segments of the shilas that you get, okay? And the shilas that we get and throw them off into you on your shoulders is maybe we could pick a few areas and get multiple physicians from across the country, rebut them who are interested in medical halacha, sit down in a strategic planning brainstorming session. And where's the greatest needs? What are the things that we really should try to focus on and get people involved? Bring people from Israel to it, people who are doing artificial intelligence, people machine learning. What do we know about it? And I think a lot of it can come out of it and really be very resourceful for patients, not just docs, and what we're doing. Until we have really data-proven false positives, false negatives, sensitivities, specificities, we got to be careful. And even the fasting issue is as you know, is someone says you use the shiurim for it, use no fast, go home, get IVs, do this, do that, which is right, which is wrong. We know about the Yom Kippur syndrome. More babies are born in Yerushalayim the day after Yom Kippur. We know why that is.
That's
okay.
Right.
But I think from fundamental, it goes beyond it. It goes in can we reduce stillbirths? I sit here saying to you, I'm very aware of that issue. I lost a grandchild at 38 weeks, and which I think may have been preventable, but let's not go there. But at the end of the day, this is way after I did the work in the 70s, because that's not when I had grandchildren, about the biophysical profile. How do we reduce stillbirths? So this device beautifully can help us do that. I don't think that's not a hard sell to me. It's right there. It's doing it. Okay, no. I'm convinced. I'm convinced that any ultrasound device that bring to the patient and you can incorporate with other things, not an isolated one. It's not a toy. I always say ultrasound is not a toy. It's a weapon. Used appropriately, it's incredible. Used inappropriately, it's a weapon. And so we've got to be very careful as we talk about all these advances. How do we bring them together and focus on the greatest priority? And that's where I'm saying, let's think about it, brainstorm. Can we put something together, groups of people, and have a retreat that says, what are our needs? What are your needs? What are the Sakalacha needs to say we need more information on? Because we have the power to.
Dr. Platt, people from the PUA team are already texting me that we're launching it. So we're doing it. Let's do it.
Okay,
Anyway,
good.
we'll be in touch with that. Dr. Schwartz, any parting words for our listenership? This has been a very, very really mind-blowing, insightful presentation, and just a few, let's say, closing words for everyone here who's listening live and those who will watch the recording later on.
I just think that the future is bright. I think that there's the patient needs to have a voice, and we talk about what the provider wants to do. We want to help people. We have sometimes our hands are tied because of technology. Our hands are tied because of healthcare costs. Our hands are tied because the payers control a lot of situations. But if the patient has a voice, if they hear about these kinds of things and ask their providers for that, if they can partner with the providers to push the needle on those things, that'll help build momentum. Because unfortunately, the patients are who we're all trying to help, and often they have the weakest voice because the doctor's doing the prescribing, the insurance is deciding what's getting paid for, and the patient's left with nothing. So we need to partner to really get these kinds of technologies out there, and in a way that's being used responsibly, and not for just no reason, and recognizing that everything has a balance. And excited to be part of it. And thanks for having me here.
Let me add one thing that I think is
Amazing.
I'll take from my perspective. Early on in my career, and I've done a lot of research and a lot of publications. We always got critical because we work with industry at times instead of just NIH grants. We've opened our minds. If you look at the cooperativeness between academics and industry today, we've moved our fronts forward so much because of it. Togetherness, partnership. Private-public partnerships have been so valuable to us, whether it's in prenatal diagnosis, whether it's in cancer management, whether it's drug therapy, it doesn't make a difference. We have opened ourselves by being not so hard and saying, maybe these guys in private industry have something to help us. And here's a perfect example of it. Here's a company that's spent a lot of money to bring this to the public. And with the help of academic centers, Nadav's, the other institutions, and where I've been working with, very clearly have made it happen. And I think we have to thank people's openness, allowing that, and they see the fruits of our labors are being shown here today.
Amazing. Well, the company is certainly very fortunate to have both Dr. Platt and Dr. Schwartz as advisors. And I look forward to seeing what the future will bring, to see this rolled out in the various centers. I do want to, doctors, if we're able to share, if you're able to share an email on the chat for our listeners, that would be very helpful. Some people already asked how they can get in touch with you. And if you could just provide your email, that would be fantastic.
I just gave you mine.
Everyone should have it. And really, once again, thank you very much. Looking forward to our next session where we talk about other breakthroughs, other innovations, and other ways we can help the medical / the Jewish community with all of this this new frontier. So thank you very much, doctors.
One last comment. If email me if you want my phone number, I'm glad to send that out as well, if it's easier for you.
You're a real tzaddik. Everyone, have a great night, and thank you again, the doctors, for joining us, for sharing your wisdom. And Be'ezus Hashem, the Klal Yisrael should continue to be gebenched from HaKadosh Baruch Hu's greatness, his wisdom, his chachma, and it's amazing to see it play out in everyday life.
Thank you.
Have a good night, everyone. Take care.
Thank you for inviting us.
All the best.